Today's topic is a CBS chapter. So, infective endocarditis means infection of the endocardial wall of the heart. What are the three walls of the heart? I think everybody knows it. Outer layer is epicardium, then there is myocardium, then inner wall is endocardium. This endocarditis means infection of the endocardial layer of the heart. Okay. So, infective endocarditis can be there in the pediatric age group. It can be there in the adult as well. What is infective endocarditis? A comprehensive clinical guide to the microbial infection of the endocardial surface of the heart that I was explaining 5 minutes before. We will discuss about the pathogenesis, the etiology, the diagnosis, what the treatment in the pediatric age group patients. Okay. So, let us start one by one. It is the microbial infection of the endocardial surface of the heart. Okay. What are the risk factors? Okay. And when to consider a differential diagnosis of infective endocarditis. Consider infective endocarditis in any child presenting with prolonged fever plus one of the following. What is one of the following? Congenital or rheumatic heart disease, any post-operative cardiac surgery, means after any valvular replacement, indwelling lines or pathological murmur. Indwelling lines means central venous catheter or central arterial catheter, and embolic phenomena. In all those cases, we can, with prolonged fever, in the background of all this, we can suspect a case of infective endocarditis. What is the pathogenesis? Underlying structural heart disease or iatrogenic cardiac manipulation surgery like valve replacement in the case of valvular heart disease, or any corrective procedure, congenital heart disease like TAPBC, TGA, anything like that, can cause denudation of the endocardial epithelium of the heart. It is nothing but making the endocardial surface rough, okay, which can act as a nidus for the platelet and fibrin deposition. And this process is known as non-bacterial thrombotic endocarditis. First, there is a surgery which predisposes the heart endocardium to the thrombotic plaque formation due to the rough surface. Okay, raw area serves as the nidus for the platelet and the fibrin deposition. It will lead to non-bacterial thrombotic endocarditis, and ultimately, due to the bacteremia, when there will be infection, that bacteremia will further attach to that platelet fibrin plaque and cause infective endocarditis. What are the common etiological agents? Streptococcus viridans, Staphylococcus aureus. These are nothing but the gram-positive bacteria. Many of you don't know what is gram-positive, what is gram-negative, what are the viruses, what is the bacteria. It is quite evident from the answers you wrote during the examination. ভাইরাস কি ব্যাকটেরিয়া কি সেটাই জানো না, তারপরে তো গ্রাম নেগেটিভ গ্রাম পজিটিভ ছেড়ে দিলাম. These all are the gram positive. Streptococcus, Staphylococcus, okay. Then there is enterococci. Fungal endocarditis, suspect in a sick neonate, immunosuppressant, okay, and any patient on prolonged antibiotics. What are the etiological fungal agent? Aspergillus and Candida. And lastly, culture negative. Approximately 10% of infective endocarditis are culture negative, and this is the why it is a diagnostic challenging subset, because until and unless the culture is positive, the bacteria you get are susceptible to the certain antibiotics. You cannot decide what antibiotics to be given. You can only have empirical antibiotics to start with and continue the treatment empirically. You have no clue in these cases, so it will be a challenging condition. What are the other uncommon, and this is very important, common etiological agents of infective endocarditis. In the coming NEET PG exam, we will be having questions on these. Uncommon organisms are Streptococcus pneumoniae, Haemophilus influenza, all these are gram positive. Staphylococcus epidermidis, Neisseria is a gram negative. Brucella, Pasteurella, these are the gram negative, and Campylobacter fetus. What are the intercellular and HACEK group? Coxiella bruneti, Chlamydia trachomatis, Chlamydia pneumoniae, HACEK group. What all bacteria comes under the HACEK group? It is Haemophilus, Aggregatibacter, Cardiobacterium hominis, Echinella cordens and Kingnella. Now, what are the clinical manifestations of infective endocarditis? Prolonged low-grade fever. Fever is a very important. We are discussing infective endocarditis. In the starting, I told fever with one of the other following suspected etiologies. Okay, so fever will be there. There are typical history of a preceding dental, urinary, intravenous or cardiac procedure. Cardiac surgery, central venous catheter, central line, urinary catheter, means all anything from where the bacteria will enter the bloodstream, from the urinary site, from the intravenous site, from the cardiac procedural site and any dental procedure. তার জন্য দেখবে অনেক টাইম দাঁত তোলার আগে, when before any tooth extraction, the dentist used to give us antibiotics. Why? This is the cause. It can lead to infective endocarditis later on. Prolonged low-grade fever, fatigue, malaise, night sweat, weight loss, means all the fever symptoms. Neurological can be due to embolic phenomena. There can be stroke, seizures and headache. Fever is the most important findings. Murmur, tachycardia, tachypnea, clubbing and splenomegaly. Remember, splenomegaly is also associated with infective endocarditis. Other causes of fever with splenomegaly. Can anyone tell me fever with splenomegaly? Anyone cause? এতগুলো cause a patient having fever with splenomegaly. একটা cause বলো। Commonly দেখতে পাও ম্যালেরিয়া, ভেরি গুড। আর কিছু? Hepatitis to hepatitis to it is all hepatomegaly. Leishmania can be there. Typhoid there is splenomegaly. Okay. So what are the embolic phenomena and peripheral signs? These are also potential NEET PG questions, objective type question. You will get all these. Roth spot, where you can find Roth spot, that is the retinal hemorrhages with pale center visible on fundoscopy. Osler's nodes, হাতে পাওয়া যায়, and Janeway lesions, painful nodules and painless hemorrhagic macules on extremities. Splinter nail bed hemorrhages. There will be nail bed hemorrhages and painful nodes. Okay, these are the Osler nodes. And CNS and distant emboli. What will be there? There can be hemiparesis, stroke होते पारे, तार जोन्ने hemiparesis होते पारे, hematuria, septic pulmonary embolism, arthritis. There can be CNS infection like meningitis and splenic abscess. So, what are the diagnostic tests we will do to confirm infective endocarditis? Okay. So, most important are the blood culture. Very important. In this case, echocardiography will help to look for the vegetations, where it is there, in which valve it is there, or in what part of the heart it is there. Laboratory tests for the corroborative findings and imaging. So, to diagnose infective endocarditis, there is a Duke's criteria. This is also a potential NEET PG question. Okay. Next important exam other than passing MBBS is NEET PG. So, I am also telling what questions you will get in the NEET exam. Duke's criteria, you will be asked what are the components of the Duke's criteria, or we use Duke's criteria to diagnose which disease. So, it is used in the case of infective endocarditis. It is having, there are major criteria, there are also minor criteria, like in rheumatic heart disease. Rheumatic heart disease, there are rheumatic fever, minor criteria and major criteria, like this. Positive blood culture is very important. Typical organism like Streptococcus viridans, Streptococcus bovis, HACEK, Staphylococcus aureus and Enterococci from the two separate cultures, two different cultures drawn 12 hours apart. Persistent positive culture, 3 or more drawn 12 hours apart, or majority of greater than 3 drawn 1 hour apart. Or sometimes if a single positive culture of Coxiella bruneti, because Coxiella bruneti is one of the organisms which directly affects the heart, with IgG titer of greater than 1:800. Evidence of endocardial involvement. Like I was telling, positive echocardiogram. If you are seeing any vegetations on the heart valves or a heart endocardium. Then from that you can corroborative evidence is there, oscillating intracardiac mass. I was telling mycotic abscesses in the case of fungal associated endocarditis, or new partial dehiscence of prosthetic valve and new valvular regurgitation. If any valvular regurgitation which is appearing suddenly as of now, then you can also have a positive corroborative evidence of infective endocarditis. Blood culture, and blood culture is a very important and it is the major criteria. What is the blood culture? 3 or more positive blood culture drawn 12 hours apart. Then comes the minor criteria: predisposing heart condition or intravenous drug use, fever is there, vascular phenomena as I was discussing, like major arterial emboli, septic pulmonary infarct, conjunctival hemorrhages like lost spots, Janeway lesions, intracranial hemorrhages, immunological phenomena, Osler's nodes, lost spots and rheumatoid factor positive and glomerulonephritis. These all are the minor criteria. And microbiological evidence, positive blood culture not meeting the major criterion. What is the major criteria? 3 or more blood culture positive drawn 12 hours apart is the major criteria, and anything apart from this is the minor criteria. Anyone, suppose one positive blood culture not meeting the major criteria. So from the Duke's classification, we have the definitive endocarditis, means organisms or culture, we are getting culture positive along with the vegetation or abscesses, 2 major or 1 major plus 3 minor, or all the 5 minor. Like 5 minor means predisposition, fever, there can be vascular, all. If all the minor criteria are positive, then we can diagnose, or 1 major along with the 2 minor, or 3 minor or 1 major. 1 major, 3 minor, all 5 minor, or only 2 major without any minor. Possible endocarditis, 1 major plus 1 minor. Okay, and out of 5 only 3 minor is positive, then it is possible. When we can reject, from alternative diagnosis, we are getting anything other than this. Okay, resolution with antibiotics less than 4 days. We are suspecting a infective endocarditis in a case of prolonged fever. We are suspecting a vegetation on the heart. We started antibiotic and within the 4 days the fever has gone and the patient is well. Then our diagnosis is probably wrong. So, definitive is 2 major or 1 major plus 3 minor or all 5 minor. This is definitive, confirmed endocarditis. Possible infective endocarditis is 3 minor or 1 major plus 1 minor. Now, what is the treatment of infective endocarditis? Since it is a bacterial infection and sometimes it is fungal, and as per culture, we are getting what is the bacteria causing the infective endocarditis and on what antibiotic drugs it is susceptible to. So, antibiotic are the mainstay of the management, aimed at eradicating the microorganism within the vegetation. Empirical antibiotics should be started on strong clinical suspicion and adjusted based on the blood culture report. It is nothing new, but in every case of fever, in a case we are suspecting a case of fever from the bacterial origin, we start empirical antibiotics. Like in the case of the infective endocarditis, mostly gram-positive bacteria positive organism. So we start antibiotics which causes damage to the gram-positive organisms, means cell wall attacking. And later on the basis of the culture report, we adjust the drugs. In congestive cardiac failure, add decongestive therapy like digitalis, salt restriction and diuretics. Diuretics like furosemide, thiazide. Okay, digitalis, salt restriction. In any case of congestive heart failure, this is the basic treatment. Digitalis, salt restriction, diuretics and avoidance of physical exertion. Why physical exertion is avoided? Because physical exertion can increase the myocardial oxygen demand and it will aggravate the heart failure. So, physical exertion is avoided, and also sometimes the vegetation can also dislodge from its original site and get from the bloodstream seated at some other site and causing the embolic phenomena and further strokes. What are the surgical indications? Intractable heart failure means severe aortic or mitral valve regurgitation not stabilizing on the medical treatment. We are giving beta blockers, we are giving diuretics, we are providing details. In spite of this, there is severe mitral valve regurgitation. Then we have to do surgical therapy, valvular replacement, heart valve replacement. Okay. Failed medical management, failure to sterilize blood despite adequate antibiotics level, myocardial abscess or recurrent emboli. If there is recurrent emboli or there is myocardial abscess which is difficult to treat by the normal antibiotics, then we have to open surgically. Okay, we have to reach the site. Structural emergencies like dehiscence of intracardiac patch or rupture of aortic sinus. Then we have to treat it surgically. Or any myocardic aneurysm require emergency operation. Because if any aneurysm is there, we have to treat it surgically. Otherwise, rupture of aneurysm will lead to immediate cardiac arrest and vegetation removal or valve replacement. If it is life-saving, okay, sustained antibiotic administration post-surgery prevents reinfection. If we have to replace the valve, then we have to treat surgically. If there are structural emergencies, like rupture of aortic sinus, or if there is any myocardic aneurysm, then also we have to resort to surgery other than the medical management, or if there is failed medical management, or if there is congestive heart failure not getting treated well with the antibiotic therapy and other diuretics and beta blockers. Then comes it is very rare, fungal endocarditis. Up till now, we were dealing with the bacterial endocarditis. Now comes the fungal endocarditis. Okay, fungal endocarditis is difficult to manage and carries a poor prognosis because there are very limited drugs which act on the fungus like amphotericin B or 5-fluorocytosine, and the diagnosis is also very difficult. So, it is difficult to manage and carries a poor prognosis. Okay, surgical excision of the infective tissue is occasionally attempted. In the previous slide, I was dealing like myocardic aneurysm. Okay, in myocardial abscess. In all these cases, surgical excision of the infected tissue is attempted. And high risk groups like sick neonates, immunosuppressed, prolonged antibiotic steroid use. Why it is also difficult to manage and carries poor prognosis? Here lies the reason, because immunosuppressed patients are difficult to manage. You are treating one thing and they will again develop another abscess or another emboli and anything else because they are immunocompromised. And sick neonates are always immunocompromised. Prolonged antibiotic use or steroid use. Steroid use causes immunosuppression, so it carries a poor prognosis. What are the drugs? Drugs is amphotericin B and 5-fluorocytosine. Who needs endocarditis prophylaxis? Means who needs drugs to prevent infective endocarditis? Children with congenital heart disease. Any children having VSD, large PDA. So, we will need prophylaxis for the endocarditis. Prosthetic cardiac valves means children undergoing valvular heart valve replacement for the different diseases like MS, MR, AR, AS, all those cases. Children may, if the children is requiring valve replacement therapies, then endocarditis prophylaxis is required, and previous infective endocarditis. If the child is having any history of previous infective endocarditis, then all that case also prophylaxis মানে কি? To prevent the disease from occurring. Okay, আগের থেকে অ্যান্টিবায়োটিক স্টার্ট করতে হবে যাতে ইনফেক্টিভ এন্ডোকার্ডিটিস না হয়। হয়ে গেলে তো কিছু করার নেই, তখন তো অ্যাজ পার দ্য ব্লাড কালচার রিপোর্ট আমাদের ট্রিটমেন্ট করতে হবে। When to give? Single dose 30 to 60 minutes before the dental procedure or tonsillectomy or adenoidectomy. Any surgical procedure like tonsillectomy, adenoidectomy, dental procedure, we require antibiotic prophylaxis to prevent infective endocarditis in the children having previous history of infective endocarditis, having previous history of any valvular heart disease for which the child required replacement of the heart valves like prosthetic cardiac valves, or the child already having congenital heart disease like large VSD, large PDA. In all those cases, antibiotics is usually given 30 to 60 minutes prior to the surgical procedure. What are the commonly used antibiotics? All those acting on the gram positive, mainly ampicillin, cephalaxin, clindamycin and azithromycin. So the treatment table of the streptococcal and enterococcal infective endocarditis, because these are the most common bacteria responsible for infective endocarditis. Okay, so Streptococcus viridans, penicillin, gentamicin combination, and it is prolonged therapy. Look at the duration, 4 to 6 weeks. 1 থেকে 1.5 মাস ইনজেকশন চালাতে হয়। Streptococcus viridans 2 weeks, enterococci 4 to 6 weeks, and other also 4 to 6 weeks, depending on the mostly the infective endocarditis treatment ranges from 4 to 6 weeks. 1 থেকে 1.5 মাস অবধি ইনজেকশন অ্যান্টিবায়োটিক থেরাপি দিতে হয়, because it is very difficult to treat. Already the lesion is on the heart, so we are much more careful in this. যে অ্যান্টিবায়োটিক ইউজ হয় সব মোস্টলি পেনিসিলিন গ্রুপ অফ ড্রাগস, বিকজ ইট acts on the gram positive organism. Vancomycin penicillin group of drugs e pore, ampicillin, only gentamicin is aminoglycoside. Staphylococcus aureus 6 to 8 weeks. These are the drugs commonly used. Okay, treatment table for HACEK and culture negative prosthetic valve infective endocarditis. Haemophilus, HACEK, ceftriaxone 4 weeks, culture negative ampicillin, sulbactam or gentamicin. This is also for 4 to 6 weeks. Prosthetic valves, vancomycin, gentamicin, cefepime and rifampicin. All these are 6 and gentamicin for 2 weeks. These are the drug doses. This is nothing important in your time. And then comes the key takeaways. Okay. When to suspect infective endocarditis? History of prolonged fever along with any heart disease. যদি বাচ্চার কোনো congenital heart disease already থাকে, VSD, PDA এই জাতীয় জিনিস কিছু থাকে, or indwelling lines means central venous catheter যদি থাকে যেখান থেকে ব্যাকটেরিয়া ব্লাডে এন্টার করতে পারে, জ্বর হচ্ছে, প্রলং ফিভার হচ্ছে, তার সাথে যদি ইনডুয়েলিং লাইন্স থাকে, হার্ট ডিজিজের হিস্ট্রি থাকে, দেন উই ক্যান সাসপেক্ট এ কেস অফ ইনফেক্টিভ এন্ডোকার্ডাইটিস। ওকে, মিনস হার্ট ডিজিজ থাকলে কি অলরেডি একটা রিস্ক ফ্যাক্টর আছে, তার মধ্যে সেন্ট্রাল লাইন দিয়ে ব্যাকটেরিয়া ব্লাডে এন্টার করছে, নিয়ে হার্টে গিয়ে যাচ্ছে আর ইনফেক্টিভ এন্ডোকার্ডাইটিস করছে। diagnose systematically, applies Duke's criteria. Major criteria is there, minor criteria is there. Blood culture is major criteria along with the echocardiographic findings are the cornerstone. Means echocardiography te tomak vegetations on the heart muscle, heart valves dekhte paoya jay, আর পজিটিভ ব্লাড কালচার, যেটা বললাম 3 ব্লাড কালচার drawn 12 hours apart. We have to start empirical antibiotics when we will suspect, because time is very less, and later on depending on the culture report we have to adjust. And if the patient is not improving with general medical management, then we have to resort to surgical management as well. And last, prevention of the recurrence, antibiotic prophylaxis before the dental surgical procedure in all high risk children. কে high risk children আছে? History of congenital heart disease, history of previous prosthetic heart cardiac valves, or any immunocompromised children sick neonates, children on steroids like nephrotic syndrome, or like ALL patients. In all these cases, in the case of tonsillectomy, adenoectomy, dental procedure, we have to start antibiotic 30 to 60 minutes prior of that surgical procedure. Okay, so this much is sufficient for infective endocarditis as per your level. কি causative organisms জানতে হবে? Most commonly used antibiotics, that is penicillin group of drugs use করা হয়. When to suspect আর Duke's minor criteria কি, major criteria কি, এটুকু জানলেই হবে। আর when to suspect any patient prolonged fever with history of valvular heart disease, we can suspect, or there is central venous catheter like central arterial catheter, central line করা আছে বা urinary catheter আছে, then we can suspect infective endocarditis. What to do? We have to send 3 blood culture 12 hours apart along with echocardiography. Echocardiography সঙ্গে আমরা কোরিওগ্রাফি ম্যাচ করব, তার সঙ্গে যদি আমরা rest of the ফাইন্ডিংস যদি পাই লাইক অসলাস নোট, জ্যানওয়ে লিজেন্স, রস স্পট, এগুলো বেসিক্যালি ইম্পর্টেন্ট কি কোথায় কোনটা পাওয়া যায়। রস স্পট কোথায় পাওয়া যায়, জ্যানওয়ে লিজেন্স কোথায় পাওয়া যায়, রস স্পট চোখের মধ্যে পাওয়া যায়, আর অসলাস নোট হাতে পাওয়া যায়, এক্সট্রিমিটিসে পাওয়া যায়, পেনফুল নোটস, এগুলো জানতে হবে কোন জিনিসটা কোথায় পাওয়া যায়। ক্লিনিক্যাল ফিচার্স অফ ইনফেক্টিভ এন্ডোকার্ডাইটিস। আর কি হয়, ইনফেক্টিভ এন্ডোকার্ডাইটিস ডিউ টু এম্বোলাস ক্যান লিড টু স্ট্রোক অর এম্বোলিক ফিনোমিনা। এই জিনিসগুলো মোটামুটি জানতে হবে, আর কিছু না। ইট ইজ দ্য ইনফেকশন অফ দ্য এন্ডোকার্ডিয়াল সারফেস অফ দ্য হার্ট, আর কিছু নাই। নামি ইনফেক্টিভ এন্ডোকার্ডাইটিস মিন্স এন্ডোকার্ডিয়াম ইনফেক্টেড। মোস্ট কমন কজ, এটা ভাইরাস দিয়ে হয় না, ইট ইজ মোস্টলি ব্যাকটেরিয়াল and sometimes it is fungal. Okay.